I'm Dr. Fox, and let's talk about the nerves of the neck. In this video, I'll give you a big picture view of the peripheral nervous system in the neck, with an emphasis on what the nerves are doing and which tissue targets are involved. So let's begin with some of the cranial nerves that are descending from the head to serve targets in the neck. And the first is the glossopharyngeal nerve, or cranial nerve number 9. Now, the glossopharyngeal nerve is going to have very many different targets throughout its course, but there's something to be said for what's in a name. So when you hear glossopharyngeal, you hear glosso, meaning tongue, and pharyngeal, meaning pharynx. So we should be thinking tongue and pharynx with respect to targets. So let's see how this is borne out. Well, for starters, the glossopharyngeal nerve is the major somatic sensory component of the pharyngeal plexus. So the glossopharyngeal nerve is going to exit through the jugular foramen with the vagus and the accessory nerve, and we can find it posterior to the stylopharyngeus muscle, but it's going to distribute its fibers amongst the other pharyngeal plexus fibers to return back sensory information from this plexus. The glossopharyngeal nerve is also an exception within the pharyngeal plexus. We know that the vagus nerve is the major motor to the plexus, but the stylopharyngeus muscle is innervated, that is, its somatic motor component comes from the glossopharyngeal nerve. In addition to this, so high beyond the stylopharyngeus muscle, in association with the internal carotid artery within the sheath, we have the glossopharyngeal nerve sending fibers out to the carotid sinus and body. The carotid sinus is just a dilation of the proximal part of the internal carotid artery. And there's a tiny bit of tissue known as the carotid body, which serves as chemoreceptors for blood that's passing through the internal carotid. So there are also baroreceptors within the wall of the carotid sinus, and both these chemoreceptors and baroreceptors are supplying information back to the autonomic nervous system via fibers of the glossopharyngeal. So there is a visceral sensory component from the carotid sinus and body via the glossopharyngeal nerves. The glossopharyngeal nerve is also a parasympathetic communicating nerve. So the preganglionic parasympathetic fibers, which serve the parotid gland, are complements of the glossopharyngeal nerve. And the glossopharyngeal nerve is going to have a significant role in communicating back somatic sensory, so that would be touch, as well as special sensory, that would be taste, from the posterior aspect of the tongue. So everything that's post-sulcal, including the circumvallate papillae, or specialized taste buds that are just ahead of that post-sulcal portion of the tongue. So that's about the posterior third of the tongue is being innervated both from a perspective of touch and taste by the glossopharyngeal nerve. Next up is the vagus nerve. The vagus nerve is one of the other 4 major parasympathetic nerves of the cranial nerves. The other 2 including the optic nerve, cranial nerve number 3, and the facial nerve, cranial nerve 7. The vagus nerve is quite a significant parasympathetic supplier to organs of the neck, thorax, and pelvic cavity. So it's going to send out very many branches along its route. So some of the earliest branches that leave the vagus nerves within the carotid sheath include the superior cardiac branches, sometimes referred to as the cervical cardiac branches. These are going to mix with various sympathetic cardiac branches in the neck and descend down towards the cardiac plexus, which is just anterior to some of the great vessels in the chest. There are also going to be inferior cardiac branches, also coming off of the vagus nerves within the carotid sheath. We'll have branches of the vagus to the pharyngeal plexus. These are going to be somatic motor to both muscles of the pharynx as well as some of the muscles of the soft palate, which we'll investigate in subsequent sessions. The vagus nerves also are going to send off the superior laryngeal nerves. These superior laryngeal nerves, as you recall, have both internal and external branches. The internal branches are somatic sensory and visceral motor or secretomotor to the mucosa superior to the vocal folds. And then there is an external branch, which is somatic motor to the cricothyroid muscle. And this is a unique innervation for the intrinsic muscles of the larynx because all of the remainder of those muscles are innervated by the next branches of the vagus, the recurrent laryngeal nerves. The recurrent laryngeal nerves are going to serve a multitude of functions. So when we think of them in the context of the larynx, they're going to innervate all of the intrinsic laryngeal muscles with the exception of cricothyroid. They're also going to be somatic sensory and visceral motor or secretomotor to the mucosa inferior to the vocal folds. Now the recurrent laryngeal nerves take a very circuitous route to the larynx. On the right side, the right recurrent laryngeal nerve wraps about the right subclavian artery and then jumps into that tracheoesophageal groove on its way up to serve the larynx. On the left side, that left recurrent laryngeal nerve wraps about the concavity of the aorta and ascends up toward the larynx in the tracheoesophageal groove. Now, that left recurrent laryngeal nerve is going to have the opportunity to send branches to various autonomic plexuses within the thorax, namely cardiac, pulmonary, and esophageal plexuses. Within the thorax, those vagus nerves are going to take a novel association. So instead of a left-right, they're going to take an anterior and posterior association with the esophagus, and they're going to transform into the vagal trunks. And those vagal trunks are going to go and serve the gut tube and some of the viscera of the foregut and midgut. But that's beyond the scope of this course. Also within the neck are the cervical sympathetic trunks. Now the sympathetic trunks are aggregations of ganglia connected by fibers that run the full length of the spinal cord, flanking it on both sides, but external to the spinal canal. These can be found laterally to vertebral bodies oftentimes. So here we're looking at a posterior aspect of the neck, specifically of the pharynx with the C-spine removed. And we can see 1, 2, 3 sympathetic ganglia. Now in the neck, the sympathetic ganglia fuse. They're not regular like they are at other parts of the sympathetic trunk. The most constant of the ganglia is the superior set of ganglia. This represents the fused ganglia of C1 through C4. Now the thing to understand about the cervical sympathetic trunks is that they have no direct input from the spinal cord. Because these are sympathetic trunks, recall that the sympathetic input to the spinal cord occurs at levels T1 through L2. And so to get input into that cervical sympathetic trunk, it must ascend from the thorax up into the cervical region. So if there's any interruption of the sympathetic trunk in the proximal cervical sympathetic trunk, you really knock out sympathetics to one side of the head and neck. Now that superior ganglion is going to represent the distribution point of all sympathetics to one side of the head. These fibers leave the superior ganglion and distribute to the head via what are known as perivascular plexuses. Plexus is just a meshwork of fibers, and this is a meshwork of fibers that follow and distribute about arteries on their way out to serve various tissues. They're going to have two major effects on target tissues. The first is a vasomotor effect. So these are going to constrict arteries. In particular, they'll have their greatest impact at the level of arterioles. And they will also be visceromotor or sudomotor to sweat glands along the way. Some of those superior branches, sympathetic branches, are leaving the superior ganglia and following the carotid sheath inferiorly and will head toward the heart as well. There are also middle and inferior ganglia, but these are quite variable and oftentimes not even present. In fact, the inferior ganglion tends to fuse with the first ganglion of T1 to form a larger, sometimes known as the stellate ganglion, and the middle ganglion is rarely present at all. Getting back to our trend of discussing cranial nerves, we have the accessory nerve, or cranial nerve number 11. The accessory nerve, as you may recall from previous videos, is somatic motor or efferent to both the sternocleidomastoid and the trapezius muscles. It is not afferent from those muscles. The sensory information from those two muscles is conducted from branches of C2, C3, and C4. The SEM is served by branches from C2 and C3, and the trapezius from C3 and C4. These are all considered part of the cervical plexus, so C1 through C4. The accessory nerves have a rather interesting pathway on their way to the target tissues. These arise from the spinal cord, and they are going to ascend the neck. They enter into the foramen ovale of the skull, and then they're going to leave through the jugular foramina along with the vagus nerve and the glossopharyngeal nerve. With respect to the peripheral nervous system, throughout most of the body, when we're talking about spinal nerves, the PNS can be simplified as a series of plexuses. So in the neck, we have the cervical plexus and just the beginning of the brachial plexus. These plexuses are formed from associations of ventral primary rami, or VPRs, of spinal nerves. And in the case of the cervical plexus, the VPRs that serve this are the ventral primary rami of cervical nerves C1 through C4. These are arising deep to the sternocleidomastoid muscles on either side of the neck, and you can sort of simplify this in your mind as thinking about it having cutaneous branches and motor branches. The cutaneous branches are conducting sensory information back from the skin, and they are organized coming back through or out to, depending on your perspective, through the nerve point or Erb's point of the neck, which we'll investigate forthcoming. There are also motor branches from the cervical plexus, probably the most significant of which is the phrenic nerve. So the phrenic nerve here we can see in blue. The phrenic nerve comes from branches of ventral primary rami of C3, C4, C5. The mnemonic is C345, keeps the diaphragm alive, and it's going to descend the neck. That phrenic nerve is going to be in close association with the anterior scalene muscle, and it dives into the thorax. It will insinuate itself between the pericardium and the pleurae of the lungs within the mediastinum on the way down to serve the hemidiaphragm. So there are two phrenic nerves, two halves of the diaphragm, and these are the major drivers of respiration. So any threat to the phrenic nerve or to the spinal cord at the levels of C3, 4, 5 will put ventilation in jeopardy. We also have the ansa cervicalis as a major motor branch. The ansa cervicalis here is shown in this lime green. It's the handle of the neck. You can see it distributing down, so C1 fibers form that superior loop, C2, C3 fibers, this inferior loop, and then branches go out to most of the infrahyoid muscles. The exception to this is the thyrohyoid muscle. Thyrohyoid muscle is served by branches of C1 exclusively, not of the ansa cervicalis, which we can see there. And we can also see that those C1 fibers are servicing the geniohyoid muscle. And those C1 fibers enjoy a special relationship with the hypoglossal nerve, cranial nerve 12, which helps to distribute those fibers out toward their targets. So we will have the opportunity of seeing the nerve point or Erb's point of the neck in lab. Here we can see the sternocleidomastoid muscle, and you want to look along the midpoint of the posterior margin of SCM, which is right about here, and distributing out throughout the neck are various nerves to the skin. These are going to include several branches. So let's take a look at the lesser occipital nerve. The lesser occipital nerve leaves the nerve point of the neck and it goes toward the posterior ear. The lesser occipital nerve is served by branches from C2 predominantly, and sometimes a minor component from C3 as well. There's also the great auricular nerve. The great auricular nerve is going to be the most significant nerve for dental healthcare providers, in that it's providing sensory communication from inferior and anterior to the ear. So this is the only cutaneous nerve that is going to have a branch that extends up toward the head. So we can see it in association with the parotid gland there. So the corner of the mandible, that skin is innervated by the great auricular nerve, which has fibers from C2 and C3. There's also the transverse cervical nerve, not to be confused with the cervical branch of the facial nerve, which services the platysma. This goes out to supply the lateral and anterior skin of the neck, and it is served by branches, fibers of C2 and C3. And then finally, there are supraclavicular nerves. These supraclavicular nerves can distribute certainly from the nerve point of the neck, but also from inferior to the nerve point of the neck, and descend down toward the thorax and go over the clavicle, which is why we call them supraclavicular nerves, to pick up sensory information from the clavicular, shoulder, superior, pectoral regions of the body. Beyond the cervical plexus, we also have the brachial plexus. The brachial plexus is the innervation of the upper limb, inclusive of the shoulder, and it includes contributions from the ventral primary rami of C5, 6, 7, 8, and T1. So the way that I remember this, it's kind of cheesy, but the brachial plexus is C5, 6, 7, 8, T1. And then anything above that, C1 through C4, would be the cervical plexus. Now the brachial plexus is conceptualized as having roots, which are these ventral primary rami. You can see them here in purple. And these are going to associate into trunks. So for instance, C5, C6, C7, C8, and T1. C5 and C6 will come together to form the superior trunk. C7 will just continue on to form the middle trunk. And C8 and T1 come together to form the inferior trunk. Those trunks are going to have divisions. Those divisions cords. Those cords will have terminal branches. And these branches are going to serve throughout the upper limb. We will have the opportunity of seeing some of the brachial plexus, so some of the roots and trunks of the brachial plexus, as they exit the neck, sandwiched between that anterior scalene muscle and the middle scalene muscle. So these are leaving the lateral neck. And that brings us to our assessment question for the video. And that is, an individual notices distinct numbness directly inferior to the ear. Which of the following nerves is most likely affected to cause the lack of sensation in this area? Is it the accessory nerve? Well, the accessory nerve is predominantly motor, and it serves the SCM and the trapezius. So nope, motor nerves aren't sensory. Ansa cervicalis. Ansa cervicalis is a motor branch of the cervical plexus, serving the infrahyoids. So no, that's not a good one. Great auricular nerve. Great auricular nerve is a sensory component of the cervical plexus. It is servicing the skin inferior to the ear as well as anterior to the ear in the vicinity of the corner of the mandible. So that's a good candidate. I'm liking the great auricular nerve for now. Supraclavicular nerves are also of the cervical plexus, are also sensory, but those go over the clavicle to serve the shoulder and clavicular region, so that's not a good candidate. And transverse cervical nerves are also of the cervical plexus. They're also sensory nerves, but those are servicing the lateral and anterior skin of the neck. So the correct answer, and certainly the best answer, is the great auricular nerve. Thank you so much for your time, and I'll talk to you in the next video.